Welcome to our video on bone and mineral disorders. In this lecture, we'll be discussing three disease processes: osteoporosis, osteomalacia, and Paget's disease of the bone. In each case, we'll highlight the definition and pathophysiology, the risk factors, how it presents clinically, as well as the diagnosis and management. So let's start with the definition of osteoporosis. Osteoporosis is defined as a bone mineral density that is 2.5 standard deviations below the average bone mineral density of a healthy young adult. This is assessed via a DEXA scan and usually reported as a T-score with a value less than or equal to negative 2.5 being diagnostic. Osteopenia is often thought of as a potential precursor to osteoporosis, and it's defined as a bone mineral density between 1 and 2.5 standard deviations below that of an average healthy young adult. So in terms of a T-score, osteopenia would be between a -1 and a -2.5. On your rotations, you may come across a Z-score value being used for diagnosing osteoporosis instead of a T-score. Now, the Z-score is specific to diagnosing secondary osteoporosis, such as may occur in children, young adults, and premenopausal women. The only difference between this score and the T-score is that this value compares the patient's bone mineral density to that of an age-matched population instead of an average healthy young adult. So in this case, a value that is 2 standard deviations below the mean, or less than or equal to -2, is considered abnormal. Here we see an image illustrating the decreased bone mineral density that characterizes osteoporosis. The naming of this disease actually comes from the idea that the bones take on a porous appearance. Notice the compromised bone architecture and decreased bone density, which becomes more evident as you move from left to right on this image. The pathophysiology of primary osteoporosis is that the low bone mass and quality associated with the disease are due to advanced age, often in conjunction with decreased amounts of estrogen. Now, the mechanism by which low estrogen can result in decreased bone mineral density is complex, and it's not totally well defined, so it's beyond the scope of step 2. Secondary osteoporosis also involves low bone mass and quality. And the causes of this are seemingly endless, so we've worked to focus this lecture on some of the higher yield points. Now, a few of these causes include vitamin D deficiency, excess cortisol levels, such as would be seen in Cushing's syndrome, as well as prolonged steroid use. Vitamin D deficiency will be discussed in greater detail later in this lecture. The next slide that we'll introduce will help highlight the excess cortisol levels and the prolonged steroid use as causes. Cushing's syndrome, which is a disease of excess cortisol levels, leads to osteoporosis through a variety of physiological changes. There is decreased intestinal calcium absorption and decreased renal calcium reabsorption. As a result of this decrease in calcium levels, there is decreased bone formation. Finally, patients experience increased bone resorption, which of course leads to the decreased bone mineral density classically seen in osteoporosis. Prolonged steroid use may actually work similarly by decreasing bone formation and increasing bone resorption. Be on the lookout for a question stem describing a patient who has been taking steroids for another condition and now develops a bone fracture after minimal trauma. As far as risk factors go, we've tried to boil this down to the most relevant within the categories of non-modifiable, or those things that the patient doesn't really have complete control over. And then there's modifiable, which are those areas that the patient can directly impact. Now, decreased estrogen due to any cause, low body weight, female gender, hypercortisolism, malabsorption from something like celiac disease, and chronic illnesses such as rheumatoid arthritis, liver disease, and kidney disease are examples of non-modifiable risk factors. Now, females have a lower peak bone mass and smaller end plates at the vertebrae, making those prime targets for this disease process. Now, examples of modifiable risk factors include smoking, a sedentary lifestyle, prolonged corticosteroid use, and vitamin D deficiency. Now, smoking is a risk factor that tends to show up a lot in question stems, so keep that one in mind. And living a sedentary lifestyle is an easily modifiable risk factor, with weight-bearing exercises being known to actually increase bone density. Here's a question for review. An 18-year-old female soccer player presents to clinic with shin pain after a minor fall during a recent game. She's diagnosed with a tibial fracture. The patient's BMI is 17.5, and she states she has not had her period in over a year. What is the pathophysiology of this patient's condition? Okay, so we have a young female athlete who is significantly underweight and has amenorrhea. This patient's history and presentation of an easily fractured tibia should remind you of the female athlete triad. This triad consists of disordered eating, menstrual irregularities, and osteoporosis. The pathophysiology of this condition is that the eating disorder leads to a low energy state and high cortisol levels. In this low energy state, patients have decreased GnRH, so there's less secreted from the hypothalamus. This leads to decreased levels of LH release from the pituitary gland and decreased estrogen secretion from the ovaries. Now, these low levels of estrogen can lead to secondary osteoporosis and the menstrual irregularities. Now, because the hypothalamus is to blame for the lack of a menstrual period in many of these patients, you may see this referred to as functional hypothalamic amenorrhea. Additionally, the stress this condition places on the body causes increased cortisol levels, which can also contribute to that secondary osteoporosis. We'll now introduce an algorithm that will be referenced throughout this lecture as we look to distinguish these three bone and mineral disorders. Notice at the top that things like bone pain, fracture, or bone deformity of any kind are common tip-offs that you might be dealing with one of these diseases. They're good clues. After that, the key is in the specific clinical presentation. Each of these specific clinical findings will be highlighted as we go, and the corresponding lab values will also be highlighted. In the case of primary osteoporosis, the classic vignette is an elderly man or postmenopausal female who presents with a bone fracture in the setting of minimal trauma. Now, it could be the elderly male with a midline spinal tenderness and a subsequent vertebral compression fracture after lifting something heavy, a postmenopausal female who fractures her femoral neck when stepping off a curb, or a patient who falls on an outstretched hand and fractures their distal radius. As was mentioned, concern for a bone or mineral disorder should prompt you to get labs, and a good place to start is by ordering calcium, phosphorus, alkaline phosphatase, and PTH levels. And in osteoporosis, each of these values will be completely normal. This is because this disease process is more related to advanced age and decreased estrogen than it is a nutrient deficiency or a pathologic process. Now, given the normal lab values associated with osteoporosis, we use the DEXA scan as the gold standard for diagnosis, with a T-score less than or equal to negative 2.5, and that's consistent with the disease. So again, normal labs, abnormal DEXA. There are a couple of additional points to make regarding the dual energy X-ray absorptiometry, or DEXA scan. And again, that's the gold standard diagnostic tool for osteoporosis. Now, this should actually be considered part of routine screening in women 65 and older. In women less than 65, or in men of any age, this test can be ordered if significant risk factors are present. So examples of risk factors that might indicate that the clinician should order this test younger in a female or at any point in a male was actually discussed previously. They include things like smoking history, long-term steroid use, a history of a prior fracture, and low body weight. Another important factor in the workup of osteoporosis, particularly in premenopausal women with a low bone mineral density, or fragility fractures, is to evaluate for secondary causes. Start with a complete blood count, which provides a systemic evaluation of many diseases. And a low TSH could help indicate hyperthyroidism, which can be associated with osteoporosis. And measuring 25-hydroxyvitamin D is important to rule out vitamin D deficiency, which again we'll address later in this lecture. We order creatinine and aminotransferase levels to assess renal and hepatic function, given the association between kidney and liver disease in patients with osteoporosis. Finally, a urinary cortisol level can help clue you into something like Cushing's syndrome. Let's tackle an integration question. An older gentleman comes into the office to review his DEXA scan results. The scan is consistent with osteoporosis, particularly within the vertebrae. What results on a CBC would raise concern for multiple myeloma as a secondary cause of this man's osteoporosis? Okay, so an older guy presents with a DEXA scan that's consistent with osteoporosis, particularly in the vertebrae. So when you think back, primary osteoporosis is more common in older women than it is in men. Multiple myeloma, however, is more common in older men, and it preferentially targets the vertebrae. So it's important to consider this disease as a cause of the secondary osteoporosis in this patient here. Now, the initial workup of multiple myeloma could include a CBC, where we would expect a generalized decrease in blood cell levels. As more myeloma cells take up space in the bone marrow, serum levels of red blood cells, white blood cells, and platelets all decrease. The most common finding is decreased serum red blood cells. In the case of primary osteoporosis, we would expect the CBC to be normal, as long as the patient didn't have any other significant pathological conditions. We'll now look back at our algorithm for the management of osteoporosis listed in green. As far as pharmacologic treatment, first-line therapy includes bisphosphonates, calcium, and vitamin D. Bisphosphonates work by inhibiting osteoclasts so that the bone can be maintained instead of broken down. And non-pharmacologic treatment includes weight-bearing exercise to strengthen the bones. There's also smoking cessation, that's a modifiable risk factor, and increased caloric intake. Now, there's a few additional points to make regarding bisphosphonates. Recall that bisphosphonates can irritate the esophagus with reflux, or esophagitis, and ulceration. Now, because of that, they should actually be avoided in patients with esophageal strictures or other conditions that delay esophageal emptying, because you don't want it to sit in the esophagus longer than is absolutely necessary. Now, to help prevent these complications, patients should be counseled to sit upright and drink a full glass of water when taking the medication. Denosumab and teriparatide are medications that may be used in patients that don't tolerate bisphosphonates very well. Raloxifene is a selective estrogen receptor modulator, or SERM, and that can be given to osteoporotic patients that don't tolerate bisphosphonates or are at risk of invasive breast cancer. And it can also be given as first-line therapy for the prevention of osteoporosis. And this drug is particularly high yield because of its unique mechanism of action. And we'll highlight that on the next slide. Raloxifene is a medication that alters estrogen receptors differently depending on the tissue that it's interacting with. It has estrogen agonist activity at the bone, meaning that it helps to promote bone growth, hence its use in both prevention and treatment of osteoporosis. It has estrogen antagonist activity at the breast, and can thus be helpful in preventing breast tissue proliferation and subsequent breast cancer. Because of this, raloxifene is useful in patients at high risk for breast cancer, especially if they're also at risk of having or have already developed osteoporosis. And that kind of makes sense. This patient has breast cancer, and you're going to give this to them. You think, well, might as well have this agonist activity at the bone to increase their bone strength. Now, finally, the estrogen agonist activity of this medication causes patients to enter a prothrombotic state. Because of this, we do not give this medication to patients at risk of or with a history of things like DVTs or PEs. This same principle holds true when deciding whether to prescribe a patient oral contraceptives or not. We're worried about that prothrombotic estrogen activity. We will now turn our attention to osteomalacia. We'll present the information in the same fashion as we did with osteoporosis, starting with definition. Osteomalacia is a defect in bone mineralization seen in adults suffering from severe vitamin D deficiency. This slide is meant to help us understand why patients with vitamin D deficiency experience defective bone mineralization. So this process starts with the patient experiencing decreased 125 dihydroxyvitamin D levels, which results in decreased calcium and phosphorus absorption in the intestines. As a result of these subsequent low calcium levels in the blood, PTH is released. This PTH release results in a relative increase in calcium levels, but a further decrease in phosphate, such that the net effect is low, but nearly normal calcium levels and severely low phosphate levels. Now, this decrease in calcium and inorganic phosphate deprives the osteoblasts of the two essential materials that are used to mineralize the osteoid matrix. Now, for a more detailed review of vitamin D metabolism, take a look at our lecture entitled Calcium Homeostasis within the Endocrine Physiology section of our Step 1 content. The major risk factors for osteomalacia are listed here. It can be boiled down to the patient not having enough vitamin D to begin with, such as in cases of inadequate intake due to a poor diet or limited sunlight, or not being able to use the vitamin D that is brought into the system. We're thinking patients that have defective absorption or defective metabolism. Now, examples of defective absorption include intestinal bypass surgery and celiac disease. Examples of defective metabolism include chronic kidney or liver disease. The clinical presentation for these patients is similar to that of the other bone and mineral disorders, so you'll need to hone in on the unique risk factors and subsequent workup in making a diagnosis. Now, patients may experience generalized bone pain, proximal muscle weakness and cramps, and difficulty with ambulation. Now, while we're here, it's worth mentioning the clinical presentation of rickets, which is vitamin D deficiency in children, because the findings are actually distinct from those of osteomalacia, and so those distinctions are highly testable. Regarding osteomalacia, this can occur in patients that are breastfed, but don't receive vitamin D supplementation. In this condition, bone mineralization stops working properly at sites of rapid growth. So frontal bossing is an enlargement of the skull that will be further highlighted when we discuss Paget disease of the bone. Rachitic rosary is when the costochondral junction is affected and can be seen as bony notches protruding at the skin. And we'll show an x-ray of what this looks like on the next slide. Now, genuvarum and bowing of the bones is perhaps the most well-recognized feature of this disease, and it'll be highlighted in a couple of slides. You're just thinking of that bow-legged appearance. Here we see an x-ray of the chest in a pediatric patient with rickets. Notice the thickened and prominent costochondral junctions on the right side of the chest. The naming of this condition comes from the fact that it looks like beads on a rosary. Here we see another x-ray, this time of the legs. And one thing you should quickly notice is the significant outward bowing that occurred at both legs. Also notice that the growth plates are widened. Now, both of these findings can also classically be found at the wrists. Again, the cause of both of these complications in rickets is defective bone mineralization. Returning to osteomalacia, let's do a quick question. A patient with celiac disease presents for yearly follow-up complaining of recent bone pain and proximal muscle weakness. What would be expected when looking at this patient's serum alkaline phosphatase levels? Okay, well, the patient presents with complaints of bone pain and proximal muscle weakness, which, in addition to difficulty ambulating, are part of the clinical presentation of osteomalacia. This patient also has celiac disease, which is a known risk factor for osteomalacia because it leads to malabsorption of calcium and phosphorus. And based on the diagnosis of osteomalacia, we would expect the serum alkaline phosphatase to be elevated. Now, alkaline phosphatase is an enzyme that is found to be elevated when there is increased bone cell activity, which is occurring in patients with osteomalacia as the bone is remodeling in an effort to compensate for the bone mineral deficiencies. Our algorithm shows the unique lab values that characterize osteomalacia. As discussed in our pathophysiology slide, calcium will be decreased, phosphate will be decreased significantly, and PTH will be elevated. Alkaline phosphatase levels are also going to be elevated, as explained in our previous question. In addition to the just mentioned lab values, patients will of course have a low level of 25-hydroxy-vitamin D. Importantly, providers should not order a 125-dihydroxy-vitamin D level, at least not when you're evaluating for vitamin D deficiency. You see, that's the active form of the molecule and could be low, normal, or high in these patients. So it's not really useful clinically. So you want the 25-hydroxy-vitamin D. Now, X-ray can be helpful in these patients and may show pseudofractures and cortical thinning. Now here we see an X-ray of the legs in a patient suffering from severe osteomalacia. The large arrow on the bottom is pointing to a severely deformed femur, and the small arrows at the top of the image illustrate the pseudofractures mentioned on the previous slide. They're seen as thin, hyperlucent regions in the medial aspect of the shaft of the femur. The management of osteomalacia is fairly straightforward, as shown by this green box. So we give vitamin D and calcium. Recall that vitamin D is necessary for proper calcium absorption. And one of the reasons that we opt for calcium supplementation is that low calcium consumption can also contribute to osteomalacia. So you want to make sure that they're actually getting enough going into their body, in addition to having the vitamin D to help absorb it. We'll round out this lecture by discussing Paget's disease of the bone. And here's a reminder of the concepts we'll cover. So we're going to start with the definition of Paget disease. Paget disease of the bone is characterized by a high rate of bone turnover and subsequent disordered bone remodeling. The root of the problem is dysfunctional osteoclasts, which we'll highlight on the next slide. There are 3 phases that characterize this disease: the osteolytic phase, the mixed phase, and the osteosclerotic phase. To understand this, we'll need to start by recalling that osteoclasts are responsible for consuming or resorbing bone, while osteoblasts perform as the builders of bone. As mentioned, the osteoclasts are dysfunctional and hyperactive in this disease. In the osteolytic phase, osteoclasts are overactive and they're consuming bone. In the mixed phase, both osteoclasts and osteoblasts are working simultaneously, and that's problematic because the osteoblasts aren't able to lay down bone properly. Now in the final phase, osteoblasts are rebuilding bone the best that they can. However, the process is disorganized and asynchronous with excessive osteoclast activity. And this new bone is weak and mosaic in appearance. So let's take a look at this on a pathological slide. Here we see a pathology slide of a patient with Paget's disease of the bone. And this image does a pretty good job of illustrating the mosaic or jigsaw puzzle appearance that the bone ends up having in these patients. It's difficult to determine the exact risk factors for this disease, because the etiology is uncertain. We do know, however, that this is most commonly seen in adults older than 55, and it's actually a highly prevalent disease process. Clinically, these patients are frequently asymptomatic, and a diagnosis is actually only made on routine labs. Now, when symptoms do appear, they're the result of abnormally built bone. Patients may have bone pain and pathological fractures of areas that don't normally break, such as the long bones and the spine. Now, the classic patient exhibits skull deformity with frontal bossing. Let me show you what this looks like. Here we see an X-ray showing the skull findings in a patient with Paget disease. Notice the thickening of the skull present throughout. The classic vignette is a patient that can no longer fit into their hat. Another very commonly mentioned symptom is hearing loss. There are also a variety of complications that can accompany this disease process. Due to the volatile nature of the bone remodeling process, osteosarcoma may develop. Now, osteoarthritis is also frequent as bone changes may occur at the joints. And that makes sense. If you're getting a lot of this Paget disease of the bone at the joints, naturally that's going to hurt. So they get osteoarthritis. Finally, patients may develop high output heart failure. And this is likely a result of the increased vascularity of the remodeling bone and the heart's inability to pump adequate blood to meet the demand. Here's an important question. A 68-year-old man comes in for a checkup with no major complaints other than some hearing loss, which he attributes to getting older. As further history is obtained, he admits that he regularly needs to adjust his hats and wonders why his head seems to be getting bigger. What is the main lab value that would be altered in this patient? Okay, an older man has no major symptoms other than minor hearing loss and changing hat size. These symptoms should make you think of Paget disease of the bone, and this causes thickening of the skull, as we discussed earlier. It can also lead to hearing loss by a mechanism that isn't completely understood. Now, in Paget disease of the bone, the only lab value that is changed is an elevated alkaline phosphatase. And as we mentioned earlier, alkaline phosphatase is an enzyme that is elevated in connection with increased bone remodeling. And increased bone remodeling is the key process occurring in this disease because of the dysfunctional and overactive osteoclast. So naturally, lots of remodeling is going on, so alk phos will be high. So as far as diagnosing Paget disease of the bone, a significantly elevated alkaline phosphatase level is key, with the calcium, phosphate, and PTH usually being normal. Recall from earlier that alk phos is associated with bone remodeling. In addition to the lab findings just mentioned, it can be helpful to obtain an X-ray. This may show lytic areas early in the course as a result of osteoclastic activity and regions of cortical thickening later in the disease, because at that point the osteoblasts try to build back the resorbed bone. A radionuclide bone scan may even be more helpful actually, because there will be areas of focal uptake at the sites where lesions with current activity are present. So it can really key you in to where that remodeling is taking place. Now finally, the procollagen type 1 N-terminal propeptide, or PINP, as well as urine hydroxyproline, can actually be measured. So PINP and that hydroxyproline in the urine. And both of those are evidence that the bone is being turned over more than usual. This image depicts a radionuclide bone scan in a patient with Paget disease of the bone. The darkened areas are where radionuclide has been taken up in significant amounts.
In particular, we see lots of this in the left pelvis.
This indicates active lesions where there's significant blood flow and remodeling of the bone. The management of this disease is right on par with the other diseases mentioned. We give bisphosphonates like alendronate, vitamin D, and calcium. Now there's one final point here on management in addition to what we just mentioned. In cases that are mild or asymptomatic, the patient can simply be observed and wait for the development of symptoms. There's not actually a huge rush to go in and start prescribing them medications, at least while they're asymptomatic. Let's conclude this lecture with a clinical vignette. A 38-year-old woman arrives to the emergency department with sharp pain on the thumb side of her lowest right arm. She says she tripped over one of her children's toys and landed on her wrist about a half hour ago. Her past medical history is significant for 2 uncomplicated vaginal deliveries and a radical hysterectomy with bilateral ovary removal performed 3 years ago due to uterine cancer. She takes no medications. Blood pressure is 118/82, pulse is 87 beats per minute, respiratory rate is 18 breaths per minute, and temperature is 37.3 degrees Celsius. BMI is 23. Physical exam reveals the right forearm to be tender to palpation distally. There's a small bump protruding from the wrist. X-ray confirms a fractured right radius. which of the following diagnostic test values would be expected for this patient? A. Decreased red blood cells. B. Elevated PTH. C. Elevated alkaline phosphatase. Or D. T-score of -3. Okay, so a middle-aged woman presents with a fracture caused by minimal trauma. Now, by her age, we would expect this woman to be premenopausal, but due to a radical hysterectomy with bilateral ovary removal, she has essentially entered premature menopause. Now, given these two facts, and the mention that she doesn't take any estrogen replacement, we would expect this patient to have osteoporosis secondary to decreased estrogen levels. And the diagnosis of osteoporosis is made after a DEXA scan reveals a T-score less than or equal to -2.5. So the correct answer is D, a T-score of -3. Answer choice A is incorrect because we would expect normal levels of red blood cells as long as there are no other pathologies in this patient. Now, decreased levels of red blood cells paired with bone fractures would be more indicative of multiple myeloma as opposed to osteoporosis. Now, answer choices B and C are incorrect because in osteoporosis, alkaline phosphatase, calcium, phosphate, and PTH are all normal. And this is because this disease process is mainly due to decreased estrogen rather than some pathological process. And as mentioned earlier in this lecture, we're not quite sure why this decreased estrogen causes osteoporosis. An elevated PTH and alkaline phosphatase would be more indicative of osteomalacia, where calcium and phosphate are decreased, while PTH and alkaline phosphatase are increased. An elevated alkaline phosphatase with normal calcium and normal phosphate and normal PTH would indicate Paget disease. Again, in this patient's case, our patient, who has osteoporosis, we'd expect a T-score less than or equal to -2.5. So again, the correct answer is D, and that concludes this section.